Welcome and thank you for taking time to engage in this presentation. My name is Jessica Gomes. I am a physician assistant and assistant professor, subject matter expert in AI, presenting along with my colleagues here at SHP's Department of Physician Assistant Studies and Practice at Rutgers. I'm excited to share our work on artificial intelligence integration and simulation-based training to enhance healthcare learners' ability in delivering difficult news.
I am Dr. Melissa Eisman. I'm a lecturer here at SHP, and I direct a course called Skills of Patient Assessment.
I'm Dr. Nkechi Mbadua. I am a lecturer at SHP and a simulation educator at the program.
And I'm Dr. Dipali Ye. I work here at SHP as a coordinator for simulation and IPE.
So delivering difficult news is a crucial yet often underdeveloped skill in health professions education. Poor communication can negatively impact patient trust, satisfaction, and overall care outcomes. Through AI-driven simulation, we aim to bridge this gap and improve the way future healthcare providers navigate the challenges of difficult conversations. In this session, we will explore three key objectives. First, we'll examine how AI-driven tools and simulation technology can enhance learners' ability in delivering difficult news with empathy and clarity. Second, we're going to look at the development of AI-driven simulation through AI-driven virtual standardized patients, VSPs, and how they foster interprofessional collaboration. And then finally, we kind of want to discuss the strategies of integrating AI and simulation into programs in order to improve patient and learner outcomes. And as you go through this presentation, I really encourage you to think about how these strategies can be applied for your own program.
So why did we embark upon this research? As PAs, we are required to deal with difficult emotions and life and death matters. Each of the speakers here today have personal experience delivering difficult news. As for myself, in my experience working in an emergency department, delivering difficult news is something that I did regularly. Now, that's not to say that I didn't deliver good news as well. However, delivering good news is a lot easier than delivering difficult news. So we embark on this research to provide our students with the ability to practice delivering difficult news in a judgment-free environment. According to a study by Sobczak et al., 93% of the participants believe that delivering bad news to patients was a very important skill, but only 43% felt that they had the training to do so effectively. Furthermore, studies have shown that many healthcare providers report feeling unprepared and uncomfortable delivering difficult news. Structured training programs, such as those using the SPIKES protocol, or setting, perception, invitation, knowledge, emotion, and summary, have been shown to improve providers' confidence and competence in handling emotionally charged conversations. Compassionate communication fosters trust and therapeutic alliances between providers and patients or families. Effective delivery of difficult news ensures that patients understand their condition, feel supported emotionally, and are better equipped to make informed decisions. We know about the discomfort that providers feel and the dissatisfaction of patients that occurs. Many medical education programs lack comprehensive curricula for teaching advanced communication skills. Learners often rely on chance observations during clinical rotations, which may not provide adequate exposure or structured feedback. So as educators, we wanted to improve our training program so that students would feel more comfortable in delivering bad news or uncomfortable news in a compassionate way with good bedside manner. Curricula that include role play and simulation exercises allow learners to practice communication skills in a safe environment before applying them in real-life scenarios. This reduces stress and enhances skill retention. With that in mind, this research outlines the development of a communication curriculum for healthcare students, focusing on delivering difficult news to patients and their families. The project will integrate AI-driven support via virtual standardized patients or VSPs, simulation-based training with in-person standardized patients, SPs, and interprofessional education or IPE modules. The specific goals for this curriculum are to enhance learners' communication skills, improve patient and family satisfaction, promote collaboration across healthcare professionals, and evaluate the effectiveness of the curriculum through surveys and feedback.
So the integration of AI simulation and IPE for communication exists also because we have standards we have to meet. There are accreditation standards, and SSIH, the Society for Simulation in Healthcare, has standards that we can meet also. These are also relevant because they are integral part of the strategic plan outlined for the School of Health Professions and for Rutgers Health, actually. And what's fantastic is that the IPEC, which recently met in November, has brand new core competencies related to communication that allow us to meet through AI and simulation and IPE. And when we talk about communication, it allows us to have this triangulation where artificial intelligence can be delivered through healthcare simulation to ensure that we're meeting interprofessional education competencies for communication.
And to address this need, we've developed a comprehensive, multifaceted training approach that integrates AI-driven support tools, high-fidelity simulation, and structured feedback mechanisms. This approach provides learners with a psychologically safe environment to practice communication skills before they go out and engage in real-world patient interactions. As part of this initiative, we've developed an AI-powered VSP using ChatGPT, which dynamically simulates a range of emotions and responses, which include anger, sadness, relief, shaking their head, providing silence, based on the learner's communication style. In this case, the virtual patient we call Mr. Smith or Mrs. Smith will respond to real-time interactions to the student's delivery of difficult news. After practicing with the VSP, students will then transition into an in-person simulation with live standardized patients. These SPs allow them to refine their skills in a more realistic and interactive setting. This progressive learning module really builds the confidence and ensures students to be better prepared for emotionally challenging conversations. To continuously enhance the training experience, we are incorporating learner and faculty feedback through surveys, debriefing sessions, and these feedback really help refine both the AI-driven and in-person simulation, ensuring that a diverse and effective learning experience is tailored to the needs of our students. To address the barriers to communication, including implicit bias and healthcare inequalities, we're also enhancing our VSPs to be better reflective of diverse experiences and backgrounds of a real-life patient. By diversifying our VSP's role, we can expose learners to a wider range of patient perspectives, helping them develop more empathy, cultural competencies, and effectively communicate with these patients that they might not have experienced in the past. One of the key innovations to this approach is to use the VSP and leverage the large language model of ChatGPT and creating a realistic AI-driven patient interaction that allows the learners to practice delivering this difficult news in a more structured and psychologically safe environment. The example that we like to give is a learner might engage with a VSP portraying a patient of an underserved community, a non-English speaker with an accent, someone with limited healthcare literacy. These VSPs are expressed in a range of emotions and cultural responses, such as disbelief, fear, mistrust, challenging learners to really learn to navigate and communicate barriers in a real-time experience. By practicing with these diverse and adaptable VSPs, students gain exposure to a more complex real-world patient interaction, and they are better prepared to communicate passionately and equitably in a clinical practice.
So we developed an AI VSP using ChatGPT, simulates patients' reactions, like Dr. Gomes had said. And what's fantastic is it facilitates this multifaceted training approach we have. We believe in a lockstep mechanism. So they would interact with the VSPs, and then they could potentially follow it up with in-person standardized patients as well in what's called a high fidelity scenario. And so this is where you have both in-person actors playing the patient, but you can also integrate AI-powered virtual patients. For example, simulating a family member who is part of the team that receives that difficult news. And this further diversifies the learning experiences for our students. But you really do need a simulation educator to be a part of your training team to make this happen. So when you do this combination in your high fidelity scenarios, say you have a student group coming in, you can go ahead and pre-brief them, prepare them for what they're about to address. You can tell them what the objectives are. any safety issues, outline the format if you need to. Once they come into the high fidelity simulation lab, you can even have a screen up where your VSP can come through if you have a live patient as well, or vice versa. And then when that happens, you can actually record the practice that is taking place and then go into a debriefing room and review the recording. So that's an ethnographic approach, and do a structured debriefing session. And Dr. Eisman will show you some of the structured debriefing sessions that are there, and Dr. Mbadwa. And this is really integral because it allows our students to be psychologically safe. They know that they're there to improve. It gives them the opportunity to make their mistakes, and it allows them to build empathy and build on those effective communication skills that they're learning.
With any training program, feedback is integral to really make this effective. Learners engage in self-reflection while faculty provide targeted input on communication style and language. Through this practice with AI-powered VSPs like Mr. Smith, learners are able to refine that ability to navigate emotional responses in a more safe environment, like Dr. Ye had said, before they can actually transition to a live patient, right? That standardized patient simulation. Ongoing feedback also ensures continuous improvement in both the VSP and in the SP training, and it's better reflective for real-world patient interactions for our learners.
So you have to ask yourself when you integrate this, do I want my feedback to be synchronous and asynchronous, one or the other? And it's fantastic because both scenarios allow both. Your feedback to learners, if it's synchronous, is in real time, and you can do it in a structured debriefing format like we had said. Synchronous feedback, in addition to being real time, also allows instructors to enhance engagement and maybe utilize words of motivation to the student. It promotes active participation, it allows for faster decision making, and it really becomes this very dynamic learning experience for brainstorming, for problem solving. But it does require simultaneous availability of the participants and the faculty, and may not be feasible if you're in an international curriculum across multiple time zones or scheduling constraints. If you're providing asynchronous feedback, it can be done through a student management system such as Canvas, or utilizing reflections and free text and doing qualitative research on that. Feedback can be provided after a certain time if it's asynchronous, and it's often based on collected data. AI-based simulation does offer adaptive feedback tailored to individual performance metrics, which is great if that's what we want to capture from our learners. And so the workflows can be critique. You can have some iterative posts to gather structured feedback. And in asynchronous learning environments, you do have the flexibility for users to engage at their convenience. It also allows for a deeper analysis of the data points, but it is a lack of immediacy, and that can reduce engagement and delay in the resolution of any critical issues, especially in the setting of somebody who might need to be remediated. So there's advantages and disadvantages to both.
So we've been talking a lot about providing feedback to learners. This is a crucial part for them to continue to modify their communication techniques. Feedback will be provided to learners in several ways, as we mentioned, one of which is through the virtual SP. When prompted, the virtual SP will provide strengths and opportunities for improvement. The second method of providing feedback is through faculty, which we previously discussed. And although the quality of patient communication can be perceived as subjective, it's important for multiple faculty to provide consistent and objective feedback. In addition, we want to ensure that we are assessing the students to meet accreditation standards and competencies that address providing instruction on the patient response to illness and stress. So we looked at published rubrics utilized for medical residents during an OSCE for delivering bad news. We also reviewed the SPIKES protocol, which we previously discussed for breaking bad news, which provides a framework for effective empathetic communication. So we took both of those rubrics and frameworks that we discussed and created a rubric to be utilized by faculty to provide this consistent objective feedback. Currently, this rubric that we created is not validated. So the next few slides are an example of the rubric which we created and its components, which include specific techniques within the framework of the SPIKES protocol. Included in the rubric are examples of each competency as reference supporting an objective assessment of the skill. So you can see here the first heading is establishing the setting. So asking the student or ensuring that the student is sitting down and at eye level with the patient. Next part of the spikes protocol is assessing patient perception. So asking the patient what they understand about their condition. The next is obtaining patient's invitation to receive information, asking if the patient wants more detailed information of their condition at this time. Delivering knowledge, so using clear, simple language when communicating with patients. The next, addressing emotions and providing empathy. Summarizing and developing a strategy, and then specific communication techniques. And finally, ensuring that the patient has an understanding of the condition.
Self-reflection is an important aspect of the learner process. And to that end, we've developed a self-assessment form for the learner. We used a modified OSCE rubric that we use in our program to create this form. And it's also based on the SPIKES framework. The form has two components. The first that you see here allows the student to evaluate themselves on a scale of their perceived proficiency using the SPIKES framework. For example, if they introduce themselves using their first, last name, and title, if this is all part of building rapport with the patient, if they address the patient with the appropriate name and pronouns, if they clarify the purpose of the visit, and if they sit for the throughout the visit. It also goes into if they listen without interruption, if they use jargon-free communication when speaking with the patient to ensure that the patient understands, and then checking back with the patient to make sure that they actually did understand what was being said, and so forth. The second component of the self-evaluation uses the plus delta technique for feedback and allows the learner to provide more thoughtful, open-ended feedback that the scale may not have addressed. And it further diversifies the self-reflective process. So according to the Delta Plus technique, we have Delta, which is opportunities for improvement, Plus, which is what they believe went well, and then general discussion points if it's not captured in either the Delta or the Plus, or just things that they feel were important to reflect upon.
So if this looks familiar to you, it's because we utilized it for the students to do a self-assessment, but it's originally a standardized patient evaluation of the student or learner. And it's fantastic because it kind of mirrors it. The student does their own self-assessment of all of these, but the individual playing the role of the patient also has that perspective. Did this learner do everything right? Did they have open-ended questions? Again, no jargon used. Were they positive in their reinforcement? Did they allow me to express my emotions, or did they rush the entire interview process? Did they end the questioning with asking me if I had any questions? So it's really great that it mirrors both of them.
We're going now to provide you with an example of the process our learner will undergo. The overall goal for our learner, again, is to deliver difficult news with empathy, using silence effectively to allow that patient to process the information, addressing emotional reactions with compassion and patience, of course, offering support for the next steps involving family, discussing treatment options, and providing reassurance without making false promises to their patients. So now we're going to introduce you to the VSP, who is known as Mr. Smith. And you'll hear an interaction of me talking with Mr. Smith as a healthcare provider and Mr. Smith as the patient. Good afternoon, Mr. Smith. Thank you for coming in today. How have you been since your biopsy?
John shifts in his seat, his hands clasped tightly together. I don't know, it's been hard waiting. Every little pain or ache, I start thinking the worst. I haven't really been sleeping much. I just need to know what's going on.
I completely understand, and waiting for test results can be very stressful. I want to go over everything with you and answer any questions that you may have.
John nods slowly, his fingers tightening around each other. Yeah, okay, just tell me straight. What did they find?
Well, Mr. Smith, I do want to be upfront with you. The biopsy results came back and they showed that you do have pancreatic cancer.
John's face goes still. He blinks a few times, then looks away, his jaw tightening. Pancreatic cancer. His voice is quieter now. Are you sure? I mean, how bad is it? What does this actually mean for me?
I know this is a lot to take in, and we did run multiple tests to be as thorough as possible, and the results do confirm pancreatic cancer. So what this means is that we now have a lot that we need to discuss in terms of what your thoughts are on the next steps. With a diagnosis of cancer, we do recommend you to see a medical oncologist for further testing. And that testing could be CAT scans, it can be PET scans, it can be blood work. So there's a lot that we have to do, and there's a lot that I'm sure you're going to have questions about. And I do want to be a part of that step with you, and of course, include any family that you may have that you want to talk about this with.
John exhales sharply, shaking his head slightly. A lot to do, yeah, right? He swallows hard, his voice unsteady. But what are we actually talking about here? I mean, is this something we caught early? Or is it bad? I need to know the truth.
So we won't know if we've caught this early until we get a CAT scan done. The biopsy just shows that the mass in your pancreas is cancer. So the next steps for this is talking to the oncologist, having you get your CAT scan, and then seeing as to what stage this is at. It's very overwhelming, and it's okay to take your time to process all of this.
John presses his lips together, nodding slowly, but his eyes are filled with uncertainty. So you don't actually know how bad it is yet? His voice wavers. I mean, I've read about this kind of cancer. It's usually bad, isn't it? You're not just trying to soften the blow, are you?
I'm not trying to soften the blow. It's just that we don't have all the tests we need yet in order to really determine at what stage you're at in terms of this diagnosis. And it's really important that, I can answer the questions that you have now, but that we get started on the next steps on how we can get your loved ones involved, how we can get your support system going, and me being available to you for with what questions you may have.
John sighs, rubbing his hands over his face before looking back up, his eyes glassy. I don't know what to do. He pauses, his voice thick with emotion. I don't even know how to tell my wife. What if it's already too late? What if? What if there's nothing they can do?
Well, what I recommend is that we take one step at a time before we jump to any thoughts of that there's nothing that we can do. What I recommend is let's meet with your wife together so I can answer both the questions that you and your wife may have, and I can provide you with all the information at the same time. I also want to set you up with that medical oncologist now so that we can get started and really get you the answers you want.
John nods slowly, his breathing unsteady. Yeah, okay, I guess that makes sense. I don't want to waste time. If there's something that can be done, I want to do it. He swallows, gripping the edge of his chair. But if there's not, I need to know that too. I can't just sit around hoping.
And I know this is a big moment. I know it's very overwhelming. You might not have all the questions now, so I do want to give you my phone number so that you can call me with any questions that you may have later on. I want to see you in 3 days to meet with your wife, and we'll have a discussion, and we'll set up that meeting today with the medical oncologist as well so that you can get started.
John exhales, his shoulders sagging slightly. He nods, though his hands still tremble slightly in his lap. Okay, 3 days. I guess that gives me time to process. He looks up, his voice softer now. Thank you for not just brushing me off. I don't know how to do this. But I guess I don't really have a choice, do I?
And we can continue as we talk with the virtual standardized patient to further interact with the VSP. And then at the end, the student will put in a prompt, which then provides them feedback on areas of where they could improve and areas where they excelled in, and then also provide examples. And Dr. Eisman will now go in and talk about those examples.
So just as Dr. Gomes mentioned, when prompted, the VSP will provide specific examples of areas of strengths and areas for improvement for the learners. So an example here is the VSP actually provides this exact feedback. You provided the essential information directly by saying the biopsy was positive for pancreatic cancer. You then immediately followed up with reassurance by saying, we are going to be with you every step of the way. Another example is if questions come up that you don't have right now, you're always welcome to call me. And the prompt then goes on to say, this is critical in fostering trust and ensuring ongoing support, particularly as the patient processes the information. So this is great feedback that the learner receives as to things that went well during the encounter. Similarly, the AI tool will provide opportunities for improvement with specific examples. So here's an example here. While you offered empathy, there were moments when you could have paused to explore the patient's emotions a bit further. For example, when the patient expressed being overwhelmed by the diagnosis, you could have asked more about their immediate feelings by saying something like, I know this is a lot to take in. How are you feeling in this moment? Is there anything you're particularly worried about? This could open a door for the patient to express deeper emotions, allowing you to address them more directly. So not only does it provide examples of what could have been said, but also supports the example with reasons why this is beneficial. And just one more example of an opportunity. Um, the AI tool provides suggesting the feedback to allow time for silence. You could acknowledge his concerns with something like, I can understand why you would be worried about that, and it's completely normal to feel that way. We'll know more after we gather more information, and I'll be here with you through all of that.
So you saw that there was feedback given by the Chat GPT system in an effort to let the learner know where their opportunities of improvement are and where their strengths are. And earlier in the slides, we also showed you an outline template of how we give feedback from our standardized patients to our learners in the OSCE format. And the students also do a self-evaluation as well, in addition to what you just saw on the slides leading up to this point. And that multifaceted feedback format really allows you to have a very comprehensive structure to give in feedback to your students for something that really is a difficult encounter and something that requires very specific communication skills.
So what are our expected outcomes? Throughout this approach, we anticipate several key outcomes for our learners: improved learner confidence, enhanced patient satisfaction and family satisfaction, and better preparedness for real-world clinical interactions on how to deliver this difficult news. Other outcomes that we anticipate is the goal that the students who are undergoing this VSP AI simulation, they demonstrate improved scores in their standardized communication assessment and receive more positive feedback from the standardized patients in terms of how their interaction is and the empathy that they provide their patient.
So there's been evidence, right? AI and healthcare simulation can be really effective to improve communication skills, including the specific setting of delivering difficult news. There is an AI-powered platform known as SimConverse with over 1,000 characters in simulated conversations to allow for repeat practice in various scenarios. Our learners are adult learners. As a result, they're experiential learners. So the repeat practice is really what's going to enhance their skills. It'll allow them to develop competency before the real-life patient encounters as well. And the AI systems are great. They can provide objective grading feedback. They can even provide personalized, actionable recommendations on communication performance tailored to each learner, as you saw. The online platform allows for that asynchronous delivery that we talked about before. And this increases opportunities for training. It really expands you to take your system to other learners across to a different institution, perhaps. But the data that's missing is data that is specific to delivery of difficult news, which is why we embarked on exploring this. And subsequent long-term impacts and further data on how these practice opportunities can complement traditional training methods as well. All of us are faculty here at our institution, and we understand that scholarly endeavors are part and parcel with our existence. So if you have a doctoral endeavor or participation in research is something that interests you, you can definitely utilize this not only to fill your educational gaps, again, not to add to your curriculum, but perhaps find an opportunity to replace an existing traditional structure, but it can also allow you to enhance your scholarship of delivery of difficult news content.
So we also ask for continuous feedback and improvement for our program. The goal is to continuously refine the training module based on learner feedback. So anonymous student surveys and, how they're feeling with the simulation, ways that we can further improve. These regular focus groups, regular surveys, and it all allowed us to really work on the AI patient script and allows us to adapt an evolving need and improve educational effectiveness of the tools that we're utilizing. Of course, the challenges that come with kind of integration of anything new into a curriculum occur in terms of AI itself is integrating AI can have its challenges in terms of algorithmic bias, privacy concerns, of course, funding. AI isn't free. Faculty training of a new endeavor such as AI is also a need to be addressed. It's crucial that we continue this discussion on how to implement this AI tool, especially with the ethical and responsibilities that come with adding new technology into medical education.
In conclusion, implementing a comprehensive communication curriculum is vital for equipping healthcare providers with the skills needed to deliver difficult news compassionately. Such curricula improve provider confidence, enhance patient outcomes, address gaps in formal training, and promote emotional resilience among practitioners. The innovation of using AI and simulation-based training will help fill those gaps in communication skills training.
So this is just the start. This model is centered on physician assistant education, but can easily be scaled to other health professions as well. Therefore, this could lead to interprofessional work with other programs to expand the use of AI-driven simulations. With other health professions involved, additional funding can be sought to develop not only more virtual patient scenarios, but also to be more diverse scenarios that support cultural sensitivity. As previously mentioned, feedback is always welcome on enhancing the curriculum and implementation strategies. And clearly, there are additional scholarly pursuits that can be derived from this project.
And here are our references. We invite you to please take a look. And then we also wanted to invite you to contact us if you have any questions.